Ladies and gentlemen, thank you for giving me the opportunity to talk at this conference on one of my favorite topics, which is hereditary and familial colorectal cancer. So here's a brief outline of my presentation. I will start by discussing colorectal cancer in general to give the rest of the talk some general context. Then we move on to the definitions of hereditary versus familial colorectal cancer. That can be confusing, and I will be explaining that. We will review familial colorectal cancer and then move on to hereditary colorectal cancer. That is the group of colorectal cancer tumor syndromes, of which Lynch syndrome is the most prevalent and the most important. So I will discuss most details of Lynch syndrome and will only briefly discuss the polar posis syndrome. And then, to end, I will explain a little bit of how we have organized things in my center, in my country, with respect to providing care to families with hereditary and familial colorectal cancer. So colorectal cancer, as you know, is one of the more prevalent and important cancers. These are data from the WHO Global Cancer Statistics from last year. And as you can see, colorectal cancer, both in terms of incidence and mortality, is high on the list. So there are statistics about the African countries, African parts of the continent as well in these data. And as you can see in the so-called Western world, including my own country, the rates are pretty high, the incidence rates, whereas in Africa the rates are lower. But that's not saying that these rates are so low that we find them not important. And if you dive into the literature with respect to colorectal cancer in Africa, which I had to do because, to be honest, I didn't know much about that. There were a few things that I found striking. First of all, that the literature suggests that there's a rising incidence of colorectal cancer in Africa. With discussion about the nature of that rise. Is it a true change in disease epidemiology, or is it in fact an artifact of suboptimal data? And I read that 2% of the African population is covered by high quality registries and the rest is not. So how reliable are these figures, and how reliable is this notion that the incidence is rising? Also, for me as a geneticist, with a early onset tumor always being a sort of a hint that something genetic might be going on, there was this observation, and I understand that these are data from Kenya, that 20% of colorectal cancer diagnoses were made in individuals younger than 40 years of age. So in my country, getting colorectal cancer under the age of 40 would be a very sort of strong alarm signal, where we have to consider a genetic predisposition for colorectal cancer. So whether this is sort of a statistical, I'm not calling it a statistical artifact, but in these articles that I was reading, they were speculating on the fact that sort of younger people are sort of overrepresented in that African population compared to the Western population, for example, and that could be the reason why colorectal cancer is seen more often, but not in absolute numbers, but in percentages, yes. So not sure what's going on there, but of course it's interesting. So we all know that there are stages of colorectal cancer, starting with small and harmless polyps, ending in stage 4 colorectal cancer, and your survival rates will depend on the stage of cancer. And obviously for the early stages 1 and 2, rates are much more favorable than for the later stage. And this is, of course, the reason why people have developed all sorts of efforts to detect colorectal cancer at early stages through population screening of tumor, so not of tumors, but of signs of blood loss in stool, or colonoscopy, for example. Several programs in different countries directed at identifying early stage colorectal cancer. So if we move on to the definition of the topics of my talk, then hereditary colorectal cancer, well, we usually mean colorectal cancer developed in the presence of a strong genetic predisposition. And in the practice, that's when we are talking about these Mendelian tumor syndromes, as for example, Lynch syndrome. And of course, if we talk about a strong genetic predisposition, you can always, debate how strong is strong. There's no number anywhere about this, but sort of intuitively, we all think about this as it should be about this Mendelian inheritance, a big cocktail of all sorts of weak genetic predispositions together in one single individual that ended up in a sort of strong risk. We still don't refer to that as hereditary colorectal cancer, to be honest. It's a multifactorial disease, and that is something else. But it can still mean a high risk, right? So familial colorectal cancer, that's difficult. There's a mix of definitions in the literature. Some articles simply state it's 2 or more cases of colorectal cancer in blood relatives. We in the Netherlands have defined that differently. We have defined it as those situations, those types of family histories where there is a 2, 3 or more fold risk of colorectal cancer, or a cumulative risk of 10% or more. And the reason for that being that those are the thresholds for actionability in our country. If you have a 3 or more fold risk based on your family history, then you will get a colonoscopy from age 45 every 5 years. So this is, from a genetics point of view, sort of the field of colorectal cancer. We have many spreader cases, of course, meaning single cases, and that can still be a case. Those can still be cases where genetic predisposition plays a role, but it has not translated yet in a positive family history. So that's single cases. And then we have this a big red part of the pie, termed familial risk cases. 10 to 30% of people with colorectal cancer will tell you they have a relative with colorectal cancer. And so that's sort of the general definition of this group, without any gene mutations identified. Can still be all sorts of mutations in those families, to be honest, but it's not like the classic tumor syndrome mutations. And then we have our syndromes, Lynch syndrome being the most important, most prevalent, most important because it's so prevalent. And then we have the polyposis syndromes, which are much more rare. I will just briefly discuss them at the end of my talk. If we talk about family history and risk of developing colorectal cancer, it will not surprise you that when you have a more stronger positive family history, then your risk will increase. So in this case, if you look at this part of the table, 1 first-degree relative with colorectal cancer for you as a person in that family will mean a relative risk of 2.3, an absolute risk of 9% by age 79. If you have more of those cases, it's already 4.3 or 16%. If you have a first-degree relative that was relatively young at the age of diagnosis, then it's 3.9, etc., etc. So these types of tables we use in genetic counseling, and we use when sort of compiling a strategy how to handle these situations. When is risk high enough to warrant, for example, surveillance in these families? And then here we see a sort of cartoon of the different types of syndromes. We have the non-polyposis syndromes, Lynch syndrome, the most important one. I won't go into details about familial colorectal cancer syndrome type X, which is basically a pedigree similar to one you could expect a Lynch syndrome, but without a molecular evidence that it's in fact Lynch syndrome. No genes found there. And then we have the different types of polyposis syndromes, all much more rare than Lynch syndrome itself. So Lynch syndrome was previously known as hereditary non-polyposis colorectal cancer, but it has been renamed as Lynch syndrome to honor oncology Henry Lynch, a great guy. I had the pleasure of meeting him several times, a very nice and very enthusiastic oncologist who really put this syndrome strongly on the map. he was not believed in the 60s when he said there is something like hereditary colorectal cancer, which is not polyposis, and people did not believe him. But of course, he was right, as we all now know. So this is an example of a Lynch syndrome pedigree that I've seen in my clinic. You see here a 3rd-generation family with all sorts of tumors: colorectal cancer, ovarian cancer, endometrial cancer, possibly gastric cancer. It's a long time ago, so the details are sketchy. We don't know exactly what's going on. And what strikes us most, of course, is that you have multiple cases of colorectal cancer in successive generations of the pedigree, and age of onset is relatively early. And this is, in fact, something that really fits Lynch syndrome, which is an autosomal dominant condition with an increased risk for colorectal cancer, endometrial cancer, and some other types that I will discuss shortly. And in these Lynch syndrome families, by definition, it's now part of the diagnosis of the official diagnostic terms, rules. We have a germline pathogenic variance in one of the following DNA mismatch repair genes, and there's MLH1, MSH2, MSH6, and PMS2. And if you would look at the tumors of these patients that developed because of the presence of these germline mutations, then you can find second hits. You will find loss of the protein that was coded by the gene in question. And there's also a phenomenon called microsatellite instability, which I will also discuss shortly. So this is a complicated cartoon, and I won't go into detail, but what we can say is that the genes in Lynch syndrome have when they are not damaged, they have a natural role in a particular type of DNA repair, which is called DNA mismatch repair. So sort of the opposing letters in the DNA strands, they mismatch, and that can be a single mismatch, as we see in the top left corner, or it can in fact be a small loop of multiple letters that do not fit. And these are recognized by the proteins coded by the Lynch syndrome genes. And the recognized mismatch will be sort of cut out, and there will be a resynthesis of normal DNA, and then everything is fine again. If this doesn't work, you will have a deficient DNA mismatch repair system, and that in turn results in all sorts of errors staying unrepaired in your DNA. And if these changes are in important genes, you can imagine that the function of those genes will be damaged, and that, as a consequence, can give rise to tumors. Here is this microsatellite instability. We have repetitive stretches of DNA that are called microsatellites, for example, all these A's and then, of course, these T's as well. That's just an example. And these are really sort of prone to mismatches. They can slip during the DNA replication process, and they have to be checked for correctness, of course. And if this fails, for example, things may shrink or may expand. The number of letters here will not stay normal, and you will see that as extra peaks. This, and on the horizontal axis, is the length, and this is the volume of a particular microsatellite. And you see here extra peaks. There is a change here which is not normal, and when you see that in multiple microsatellite markers, this is called microsatellite instability. And then in tumors, a more sort of a classical trick for pathologists is immunohistochemical staining for the mismatch repair proteins. This is an old slide because it should have listed this as Lynch syndrome gene proteins. And this is an example where you have normal MSH2 staining. There's all the dark spots, all the dark nuclei of endometrial cancer in this case. And in this case, on the right in the slide, there's loss of MSH2 staining. We still see the background staining, but there's loss of this nuclear MSH2 staining. So MSH2 protein is absent in this tumor, which is a clue that there might in fact be Lynch syndrome in the patient. So going talk a bit more in detail about Lynch syndrome clinic, there's a 5 to 70% risk of colorectal cancer. The 5, of course, is a strange number, and that is caused by one of the genes, and I will show you which one in one of the later slides. There's a increased risk of colorectal cancer. Age diagnosis is relatively young on average in the Western world, at least 45 years. 60% of the tumors are in the proximal colon. In 80% of cases, you will have multiple colorectal cancers. And there's also an increase in endometrial cancer, but also of other cancers. And this is a picture from one of our reviews. And you can see that you can have gastric cancer, pancreatic cancer, urinary tract cancer. That's not renal cancer, but can be the renal pielum, but not like, let's say, the clear cell adenocarcinoma of the kidney. That's not increased. It's the outflow tract of the urine. Ureter, also bladder, small bowel, ovarian cancer, and as you mentioned, endometrial cancer. All these are increased, but some, of course, more than others. Now, here's a study from the prospective Lynch syndrome database. The patients from my own center are included in this study, and we have produced together a number of papers. One of them showing the risk per gene. And here you see MLH1, MSH2, and MSH6, and PMS2, and this is the cancer risk, cumulative cancer risk for all cancers, Lynch syndrome-associated cancers together, or just colorectal cancer. And you can see that all cancers together, for MLH1 it's like 80%, MSH2 a bit more, PMS2 less. Big error bars, confidence interval bars here. And also, if we look at colorectal cancer, only 50%, also 50%, this is about 30%, and this is, well, in fact, it's doubtful whether or not cancer risk is indeed increased for PMS2, which is a strange story. So it was labeled as one of the Lynch syndrome genes, and in fact, some people say it's not a Lynch syndrome gene. Well, this is a hot debate, and there's all sorts of things that we can say about it, but fact remains that risks for individuals carrying a pathogenic variant of PMS2 is much lower than for the other ones. Once we have identified people at risk, so carrying such a mutations, what do we do for the Lynch syndrome patients? This is what we offer in our country. So there are differences between countries. This is what we offer in our country. Colonoscopy once every 2 years, starting at age 25. Ultrasound, transvaginal ultrasound, and endometrial biopsy, starting at age 40, ending at age 60. And also there's hope of chemo prevention. So this is just one picture from John Burns' CAP trial publication in The Lancet in 2020, showing that if you give mutation carriers 600 milligrams of aspirin, they will have a lower risk of getting colorectal cancer. And in fact, the risk for any cancer, Lynch syndrome-associated cancer, is a bit lower. There's still dose-finding studies going on. 600 might be a bit too much. You know, we might get the same effect with lower doses, but that's an ongoing study right now. So there's hope there for chemo prevention. How do we find these patients? Well, there is, and I haven't even discussed those in detail, traditional clinical pedigree criteria. Why did I not discuss them? Because in fact, we hardly use them anymore. We will miss so many cases, perhaps even more than 60%, if you just stick to the clinical, they were called the Amsterdam criteria. If you only use those in the clinic, yes, of course, you will identify families, but you will miss most of them. So there is a trend towards universal tumor screening for signs of Lynch syndrome that's looking into the tumors for what I explained to you as microsatellite instability or loss of mismatch repair proteins in immunohistochemical staining. In our country, there is a program that we test all colorectal cancer and all endometrial cancer under the age of 70 years for, in most cases, with immunohistochemical staining, as some labs use microinstability testing. And also what I see as sort of an upcoming trend is that it will become step by step more routine to do tumor sequencing also for colorectal cancer. And then, of course, you can also find mutations that turn out to be germline Lynch syndrome gene mutations. So now a brief summary of the polyposis syndrome. Why only a brief summary? Not because they don't have clinical and clinical challenges at all. I mean, treating these patients, the surgery can be very complicated. That's all, clear. However, the identification is different. So they are much more rare than Lynch syndrome, and they will give striking histories in these pictures. You see the colon from the inside, multiple, sometimes more, hundreds of polyps. And this is such a striking thing that even if you would not be aware of the fact that polyposis can be hereditary, you will at least sort of pick up the phone and tell your colleague, hey, look what's going on. This is a very strange situation. What's going on here? So it's more because of awareness and a recognition that I focus most on Lynch syndrome and not on the polyposis syndrome. Still, I want to briefly give you an overview, simply telling you the story that there are many genes and many types of polyposis syndromes. Of course, familial adenomatous polyposis, most famous one, but still a rare one. But there are so many others, and they all have their genes and particulars. Some of them autosomal dominant, some of them autosomal recessive. And that's in fact all I want to discuss right now about these very rare polyposis syndromes. They need very special clinical actions, but they are rare. And recognize them may not be a big problem. Sometimes it is, by the way. So finally, how to organize. And this is just an example from the Netherlands. So how to organize cares for these families and patients. Well, in an ultra simplistic view, you would say, well, we need genetic testing. That would be a horrible mistake. If you just would have a machine and people capable of operating that's not the way to do it, because you won't be able to build your what we call a care path without all the other types of health professionals. For surveillance, gastroenterologists, gynecologists, and in the first place, of course, people recognizing that there's a reason for referral to you as a specialist. You need all sorts of specialists for surveillance, diagnosis and treatment, and the follow-up after treatment. Maintenance of equipment. Those of you that run sequencers know that contracts for maintenance of those machines is very expensive and a very specialist job. And that's just talking about sequencing equipment. And you need, of course, administration. You need all sorts of support to run such a system. And we found that we needed communication specialists. Why? Because we felt the need to educate both public and professionals about, the existence of these syndromes and what to look out for, when to refer, etc., etc. That was really, that was not trivial at all. Of course, it was not easy to find funding for setting this up and doing the first cases. Currently, it's all paid for by the insurance companies, but that was not so when we started out. And of course, extremely important is that you sit together and you think things through and develop your own protocols and guidelines on how to handle these. And that should be done jointly, otherwise it won't work. There can be, of course, very nice opportunities for science. And it is very important, which can, of course, be a scientific project to evaluate what you're doing. So this took us many years to set this up and to have this up and running, but now we are sort of pretty good at doing this, but it took us years. So in summary, there is a sizable group of the population with a strongly increased risk to develop colorectal cancer, and familial colorectal cancer and Lynch syndromes are the most prevalent ones, and deserve sort of most attention. The recognition and identification of persons at risk offer opportunities for prevention. So you should put energy in this process of recognizing and identifying these persons. And again, so for me to say as a geneticist, genetic testing is just a very small part of the care path. The rest needs to be put in place as well. And so our experience is, think big, but start small. And that's my sort of basic take-home message. Thank you very much.